This video will demonstrate elective DC cardioversion in a patient with atrial fibrillation. Cardioversion depolarizes the entire myocardium, and in certain arrhythmias, for example atrial fibrillation or flutter, will allow the heart to restore back to sinus rhythm. Cardioversion must be distinguished between defibrillation, the difference being that in cardioversion, the energy is synchronized with the cardiac cycle. This avoids inducing life-threatening arrhythmias, such as ventricular fibrillation. In the emergency situation, cardioversion can be used in cases such as ventricular tachycardia or supraventricular tachycardia with cardiovascular compromise. When commencing an elective cardioversion, the most important point to check is if there is adequate anticoagulation, the risk being that in restoration of sinus rhythm, a clot could be dislodged from the left atrial appendage and embolize. NICE recommends a target INR of 2.5, with a range of 2 to 3, for at least 3 weeks prior to the procedure. Written consent for the procedure must be obtained beforehand. The patient should be fasted on the day of the procedure, as they will require brief general anesthetic. You will also need to prepare the chest adequately before starting, including shaving the chest if necessary. The chest must be clean and dry before placing the pads. The normal pad positions are at the right sternal edge and at the apex. However, sometimes you can place them anterior-posterior. This directs the energy along the cardiac axis. If a pacemaker is in place, then you may want a cardiorespiratory technician to disable the pacemaker prior to cardioversion. Continual ECG monitoring needs to be in place, and a rhythm strip should be recorded prior to and during each shock. The cardioversion machine will now be demonstrated. Make sure to familiarize yourself with your own trust machine and follow their guidelines at all times. With this particular model, turn the machine on with the dial on the left. In this case, we can lead select pads to give us the rhythm. As we have not connected the other leads, they will not give a signal. For cardioversion, the key button is sync. Here the sync button is flashing, and the word sync has appeared, designating it is on. A common energy to start with is 100 joules. Each subsequent shock will require an increase in energy as the chest impedance increases. When you are ready to shock, you need to charge the machine by pressing the charge button here. Make sure everyone is away from the patient, that oxygen is removed, and then it is safe to shock. Here are a variety of pads that can be used. Different manufacturers' pads differ in design, so make sure to familiarize yourself with the ones at your trust. They are clearly labeled for correct placement, at the right sternal edge or cardiac apex. For anterior-posterior pad placement, the heart symbol is on the anterior pad. For illustration, here are some different manufacturers' pads. Simply peel off the label from the back of the pad to reveal the adhesive surface. The patient has been prepared with ECG, blood pressure, and oxygen saturation monitoring, and the pads have been correctly placed. The patient is lied flat, and then short-acting general anesthesia is induced, in this case with propofol. When adequate anesthesia is reached, charge the machine, make sure an ECG trace is recording, and it is safe to shock. Then deliver the shock. We can see that sinus rhythm has been restored. The patient is closely monitored for return to atrial fibrillation. He will remain under observation for a few hours prior to discharge and is advised that he cannot drive for 24 hours. The patient will be followed up in clinic and a decision made regarding continuing anticoagulation.